to thank all of you for coming back, and I apologize for yesterday. It was an unusual circumstance, to say the least, but nonetheless, it happened. And I got a note from one of my fellow program coordinators from another group, and he said, this is the group organizer's worst nightmare, is when something happens and you don't make that final communication to make sure everything's right. So in any event, we take full responsibility, and Dr. Onik was good enough to agree to come back today, and thankfully the Health Connections folks were kind enough to allow us to use the room again, so we're able to continue without too much of a heartbeat loss, except for a few folks that won't make it back today. But I do appreciate everybody that's come back, and I know you'll be very pleased with what you hear today, and it'll be very informative for all of us. I do want to introduce Dr. Onik with just a very few comments, and I think they're important ones because basically last year when I first had contact with Dr. Onik's office, there were two things happening. First, my own cancer, but second was the notion of having him speak before our group. And on both scores, I might say that I was very pleased with the results, and I did not end up using cryotherapy, which is what we were talking about several months ago. But throughout my course of inquiring about both cryotherapy and about Dr. Onik speaking, I had nothing but the highest praise from every person that I spoke to. And what I'm referring to is other doctors in the community, professional people in the medical community that knew about him and his history and his bring to the fore some of the newest innovations in prostate cancer treatment. And so for that, that's to me the greatest recommendation you can get when you talk to a lot of other folks who are very, very deeply into the business. They all say, yes, get him on board. So we're thankful, despite the delay of a day, to have you come on board. And so without further ado, Dr. Gary Onik.
Thank you. The mistake was on me. I'm really thankful that you've come back because what I'm going to tell you is really, in a way, I think historic. You're going to hear, and this is really one of the first places I'm ever talking about it. I haven't given this talk at medical meetings, yet to publish this data. But yet we know, based on our results, that I believe the treatment for prostate cancer will never be the same after this gets out. So thanks for coming back. I really appreciate it, and I hope I make it worth your while. Today I'm going to basically talk about immunotherapy and tumor ablation for prostate cancer. As you know, once a patient has a recurrence of prostate cancer, either in the lymph nodes or the bones, they've been considered basically incurable. The treatment has been hormone ablation therapy, androgen deprivation therapy, takes the testosterone away, and these tumors need testosterone to grow, and so the tumors shrink, but it's not a curative therapy. It doesn't cure someone, and eventually the tumors are smart enough to kind of get around the removal of the androgen, the testosterone, and they will start to grow again. So up until this point, that was the way this was handled. And new treatments have come around with new types of androgen ablation therapy that has extended some life in patients, on average 4 months. Chemotherapy with various chemotherapeutic agents has done a little bit in terms of extending life for those patients, but it's always been basically the same. And those treatments have come with some significant downsides. Anyone who has been on androgen deprivation therapy knows that those come with significant lifestyle changes and sometimes patients can't tolerate it very well. So everything's going to change. That's what I believe. My job is to convince you. So the clues to this new treatment that I'm going to be explaining to you were there. They go back almost 30, almost 40 years. This is a picture of a man with metastatic prostate cancer that's already gone to his lungs. This patient had a cryoablation of his prostate cancer just to open up the area so he could urinate properly. And this was done back in 1971, so we're talking a long time ago, well over 40 years. And after his treatment, amazingly enough, all of his metastatic disease went away. So you treat his prostate, and cancer goes away in other places. Very interesting. They felt that this was probably due to an immunologic mechanism where his body now started to recognize his tumor as foreign and started to reject his tumor. Unfortunately, there were very few tools back then to work and try and make this a reproducible phenomenon. And it didn't work. When they tried later on to reproduce this, it really wasn't reproducible. And so this concept fell into kind of disuse. Now, I started not treating prostate cancer. I started treating liver cancer. That's how I got involved in treating cancer. Because liver cancer patients were basically hopeless. If you couldn't cut it out, chemotherapy didn't work, nothing really worked. So surgical removal was the only way to cure a patient with liver cancer. And we came along, we said, you know what? A lot of these tumors can't be cut out, but if I can kill them using something else and leave the cancer in and let the body take care of the dead tissue, maybe I'll be able to extend a kind of surgical cure to patients that can't really have it cut out, but who I might be able to destroy reliably their cancer. So that's what we did. And this is me when I still had black hair. And these were done at open operations. You can see the size of these cryoprobes. It was a big, big operation. But amazingly enough, we did cure some people. And this concept of killing a tumor and leaving it in became a standard concept in oncology. Here's a patient who had 8 lesions in her liver, treated them. Here is her liver 5 years later. There's no evidence for cancer. And she's now free of disease 30 years later. Now, why is this interesting? It's interesting because her tumors were already metastatic from a tumor in her bowel. It had gone to her liver. So what are the chances that I would treat 8 tumors in her liver that I could see, and there wouldn't be any cancer cells anywhere else that were going to grow up later? That would be kind of hard to believe. And we didn't think that we were going to get a 30-year result on her. We figured that it would help, and then she would probably have recurrences of tumors in other places in her liver. And if we were lucky, we maybe could kill some of those. But we didn't expect there to be a long-term result. How did that happen? Well, maybe it was the same phenomenon that we had with the patient with the prostate cancer that had gone to the lungs. Maybe by freezing her tumor, we created her immune system to recognize that tumor as different and to go out and seek those microscopic cancers that were going to grow up later and destroy them before they could grow up. So there was something going on. But yet we had no idea how to harness it. And we had many patients who, this patient had metastatic colon carcinoma. And we killed this large lesion. And there was no way that this patient wasn't going to have other small cancers somewhere else. But once again, none of them appeared. And this patient's 10 years since we treated that liver cancer that was metastatic from her colon. Other patients, again, when we look at our prostate cancer freezing data, something very interesting happens. On the right here, you see a typical survival curve in patients who have been treated by either radiation therapy or radical prostatectomy. What you see is this kind of inexorable downward slope. As time goes on, patients continue to fail down the line. So that's such a typical slope of a survival curve in a patient with prostate cancer. The difference between these two are that this is a high-risk patient, somebody who has aggressive cancer, a lower-risk patient, someone who has less aggressive cancer. But the slopes of those curves are pretty much the same. When we look at curves associated with treating cancer by cryosurgery, something very different. Patients fail, if they're going to fail, they fail early. Then the slope is just basically flat. We don't see that inexorable drop in survival as time goes on. And what that told us was there's something going on here. Maybe we're just better at treating the local disease, so it doesn't have time to metastasize, but maybe we're seeing something immunologic like we did in those other patients and in that first patient that I showed you those chest x-rays. Maybe there's something happening that's killing that microscopic disease, so these patients, if they get past this early phase, tend to do well. So, it's one of the reasons why I believe that if you're going to do tumor ablation, because now, once we introduced cryosurgery and it was successful, everyone came out of the woodwork and said, oh, well, I can kill it with HIFU, and I can do it with photodynamic therapy, and I can do it with microwave, and I can do it with laser, and yeah, you can do it. You can kill tissue with all of those things. But all of those methods, oh, and you can kill it with IRE, another one. All of those methods have one thing in common. They are heat-based, except IRE, and they denature proteins. So your body's not going to recognize those proteins anymore, and that's what you need to kind of stimulate an immune response. It's just like when you get your polio vaccine. So if you kill that tissue, it's like turning, an egg, hard-boiling an egg. You freeze an egg, you thaw it, it still looks like an egg. You take an egg, you boil it with heat, and it doesn't look like an egg anymore. It looks like a hard-boiled egg. And the protein structure is completely different. So that's one of the reasons why I feel very strongly that if you're going to do ablation therapy, cryo should be some portion of it. Besides the fact that we've got a really long history and we can control it and we got really good data over all that stuff. Okay? Here's a guy, prostate cancer patient. He's got this big tumor and it's already grown outside his prostate and it's grown into his seminal vesicles and it's up near his bladder, and this guy's incurable. You can't do radiation on this. You could try, but you'd injure stuff and it wouldn't work. It's Gleason N cancer. And but we wanted to control this tumor because we didn't want him to get into local problems, because this was going to keep growing and knock off and block his ureter and kill his kidney and eventually have problems with that. So we tried to destroy that cancer. His PSA was already 200 when he was diagnosed. And we did a focal therapy because actually the anterior portion of his gland didn't have cancer on this side. And killed that area, and amazingly, 10 years later, he doesn't have any evidence for cancer. Now, almost assuredly with a PSA of 200, you're going to have some microscopic cancer at least that will grow up later. So, another indication that something was going on. So, what about this ablation immunologic effect? Well, it may be a factor in that survival curve that we showed. When you look at the way we do cryo, it really isn't the best for immunologic work. It has some real downsides. It destroys structures at times, so you can't really freeze very well near certain structures. You're gonna hurt them and create complications. And it also destroys the vasculature, so that once you do a cryo lesion, it becomes avascular. So even if there are things in there that can stimulate the immune system, it's going to be hard for the cells of your body that modulate that response to get in there and see what they need to see. So cryo is not the optimal way to get this immunologic effect. So we wanted to come up with a better way. Now that we knew what we were aiming for, that we were aiming for an immunologic effect, now could design an ablation that would optimize that. And that's what we did. Now, what kind of ablation was that I'm going to talk about? I'm not going to tell you. Because right now it's still a secret. We are finding some help to bring this to more patients. And right now, we really don't want to give you the specifics because we don't want people taking this and doing this badly. Certainly can be done badly. And so, had to come up with a new ablation technology. There are now medications available that can enhance an immunologic effect. So we want to get the best ablation to release those antigens and get the effect, and we want to add anything that we have available to boost that effect and get a better effect than we could with any one of those things. And this is a very fruitful area for investigation. That's why we started. So there's a cancer immunotherapy revolution. You can't go a day without hearing something on the news about immunotherapy and cancer. That's what Jimmy Carter had for his melanoma and his brain tumors from melanoma. And he's done great. No evidence for cancer. Amazing. Previously, that was an immediate death sentence. But it's not anymore. Unfortunately, that doesn't happen in the majority of patients. It's being used in squamous cell carcinoma. It's been shown to improve, long-term survival in those patients as well. And it's being studied across the board of tumors. How have these new medications done in terms of prostate cancer? Really not terribly well. You don't have to memorize this. There will not be a test here. But there are various drugs, 1 inhibitors, ipilimumab, CTLA-4, Provenge, which you know about in prostate cancer. Take your cells, activate them with prostate cancer antigen, give them back to you so your body fights your prostate cancer. And So there are various places in this immune kind of cascade that we're trying to work on and that they have developed medications for to try and make things better. So, unfortunately, immunotherapy in prostate cancer has not been very impressive. It's been very disappointing. They have tried using the drugs that were used in melanoma. One is a drug called Yervoy, and they did a big multi-institutional phase 3 trial, and nothing happened. No survival advantage, lots of complications, and basically PSAs didn't go down, and there were no radiographic responses. So this drug was not approved for use for prostate cancer. There are vaccines that are being developed. One of them is called ProstVac. And once again, no PSA change, no tumor regression, no increase in progression-free survival, and yet drug companies are spending billions of dollars to try and find something that works in prostate cancer. Prostate cancer, unfortunately, is just not an immunogenic type tumor. Very hard for your body to recognize that it is foreign and to attack it. Provenge is approved for prostate cancer. It improves survival by about 4 months over the placebo, the people that didn't get it, but it didn't change anybody's PSA. Nobody's tumors got smaller. There was no increase in progression-free survival, and overall it was the 4 months that got it approved, but not very many doctors are really giving it because, I mean, I as a physician, I want to see something happen. I mean, I can't, it's very demoralizing to be giving people treatments and not see something that says that it's working. So I think it's more, it's psychological, but I think that's one of the major reasons why Provenge is not being used, besides the fact that it is just unbelievably expensive. So, the question is, if you can do an optimal ablation and add some of the patient's unique cancer antigens to their body so that their body sees their cancer as your body would, let's say, with a polio vaccine as foreign, so the body would then reject cancer just like your body rejects polio when you're exposed to it. Added those particular drugs, would you get something that's more useful? So we came up with an ablation that exposed those antigens, but also left the vasculature intact and allowed cells to get in. So we felt we had at least one good portion of this equation. Let me show you some pictures. This was actually the second patient we treated, but it was the first with castrate-resistant prostate cancer. Castrate-resistant prostate cancer, no one in the history of medicine, in the literature of prostate cancer, has ever gotten a complete response in a patient with castrate-resistant prostate cancer. It has always been completely incurable. No one even gets to the stage where you can say, well, they've got a chance for being a complete treatment. So this is our first patient with castrate-resistant prostate cancer, and I just treated him because here was a guy sitting across the table from me who literally had no hope. And I had been thinking about doing this type of treatment for a long time, and he was a very sophisticated patient, and he said, anything you want to do? Got any ideas? I said, well, I've been thinking about doing something for a while. And I explained it to him, and I actually explained it to his son, who was an executive in the medical device world. And he had failed everything. The tumor had invaded his bladder, had invaded his rectum. It had obstructed both of his ureters, so he had tubes in both his kidneys draining his urine. It had obstructed his urethra, so that he had a tube draining his urine from his bladder because he wasn't able to pee. He had mets in all of the lymph nodes around his pelvis, and he had had everything. Radiation, a radical prostatectomy, failed all of the hormone therapies, and he failed 13 rounds of chemotherapy. And he was basically going to hospice. He was done. Said, anything you can try. Well, tried this new, it was so new that you can't even call it experimental because we weren't doing an experiment. We were just trying to give the guy a little hope for a little while longer. And in 2 months, his PSA was basically 0. Now going on a year, and his PSA still 0. This was the mass that was growing into his rectum and growing into his bladder and pushing up his bladder and blocking off his kidneys. And in 2 months, mass was gone. Here's the top portion of that mass. And in 2 months, just this nubbin of tissue. And the lymph nodes that had cancer in them basically resolved, were gone. When we took a biopsy, there was no cancer anywhere. Anything we biopsied that previously had cancer in them, all it had was this inflammation. His body was going in, and now that it could recognize that this tumor was not part of him, it started killing it. And it killed it wherever it was. That's the neat thing about immunotherapy. The other neat thing about immunotherapy is not like giving therapy like hormone ablation therapy, ADT, or like giving chemotherapy. This lasts because it's your body that continues to find these cells if they pop up and kill them. So very often, responses in immunotherapy can be long-lasting. And that's a very exciting thing in patients with metastatic prostate cancer. Now, going on a year out, all of his tubes are out. His kidneys are now functioning. His tube is out of his bladder. He's urinating normally. He is back to baseline. Never happened before in the history of medicine. A guy like that. That's why I'm excited to be here talking to you guys. Because this is the first piece of data that says that there's another way. And that way may be better than what we're doing now, and at least will be a good alternative if we can keep and reproduce this response. Another fella, here's a relatively young guy. He was diagnosed, his PSA was 128. He had a very aggressive tumor, left side of his gland, and it was already growing outside, and he had evidence of metastatic disease on his scans already. And rather than just put him on hormone therapy and irradiate his prostate, which is what the standard would be, I said, maybe you'd like to try something new that we're doing. This could make a big difference for you. And frankly, if I was in your situation, being a young guy, fully functional, what do I have to lose? You know? Why? Well, 4 weeks, his PSA was down to about half. And, you know, when you get a hammer, you want to use it again, so I treat him again. Because I didn't know that he was going to continue to go down, but I wanted to give him a booster, because that's the way the immune system works. So we gave him a booster, and in 8 weeks, down to about 8, basically been down to negligible since that time. It was a big mass in his pelvis. Prostate cancer, already metastatic. And this is what it looked like 8 weeks later. And the stability of his PSA says that right now he is in complete remission. We don't know how long it's going to stay that way. Could be forever. We don't know. But certainly he's better off now than being on hormone therapy, having had radiation, and with the certainty that that eventually was not going to work. And he's fully functional. I mean, there's no incontinence. You know, sexually, he's perfect. I mean, who would have thunk it? So, this is called a waterfall plot. Start out at 100 or 130, and your PSA goes to 0. You've gone down basically 100% in your PSA. And we've now treated 7 patients with this treatment, all with metastatic prostate cancer. Some with castrate-resistant metastatic prostate cancer, some who had not had prostate cancer treatment at all, and certainly no hormone therapy. And we now have 3 patients out of 7 who have had a complete response. We don't even know what we're really doing yet, honestly. We are first learning. But to have a success like this, patients who previously not going to have any success with, has us really very, very excited. And I believe that this is going to be taken to the next level at some point. I think this is going to become a standard treatment in metastatic prostate cancer. It will be the first treatment that somebody has for metastatic prostate cancer before they've had their immune system ripped to shreds by all this horrible stuff that we give them. We're going to do this to these patients. The ones that get a full response, terrific. The ones that don't, then we'll put them into, you know, the usual type of treatments. But we believe that we can, right now, I think that we are going to be able to remove about 30 to 40% of metastatic prostate cancer patients from the usual and get long-term responses in these guys. And how long they're going to last, we don't know. But traditionally, immunotherapies have lasted a long time because of the mechanism by which they work. So it's the first potential cure for metastatic prostate cancer. Who would have thunk it? I mean, you know, this should have been done, this should have come out of Johns Hopkins or Harvard or Stanford. You know, it came out of Brooklyn. It's going to be a wonderful treatment. Where is this going to go? If you can take a patient and who has high-risk prostate cancer, or even medium-risk prostate cancer, who's going to have a 30 or 40% long-term chance for having recurrence someday, you can now treat them with this therapy as an adjuvant therapy when the patient still has small volumes of disease. What's amazing about the results we've gotten is these patients, we've killed off trillions of cancer cells in these grossly metastatic patients. But what about that patient that has 100 cells somewhere in their bones or the lymph nodes, and these are going to grow up in 10 years? We treat them initially with this therapy. We're going to prevent them from getting metastatic cancer. So what is the implication of this? The implication of this is radiation goes away and radical prostatectomy goes away, because those are going to do nothing for a patient's immune system, do nothing to help them avoid metastatic disease down the line. We've already proven that from local control point of view, ablation is just as good or superior to radiation or radical prostatectomy. We've proven that. There are good studies, randomized controlled trials, showing that cryo is more effective than external beam radiation in killing cancer in the prostate. Unequivocal. So if we can do just as good a job, if not a better job, in controlling the local cancer with ablation, and now we can also add an effective adjuvant treatment to prevent their metastatic disease someday, that changes everything. Why would you want to do those other treatments? And that's where we're going to be 5, if not 10 years from now. There won't be anything else. It'll be immunotherapy, local control of the cancer, using immunotherapy as an adjuvant, and decreasing the chances of patients getting metastatic disease. So we think it's going to be a revolution in prostate cancer care. I'm betting, and I'm betting my time, and bet a good portion of my money too, getting us to this point with the research that's been necessary to get it here. So thank you for coming back, and I hope it was worth it to you.
Well, thank you very much. My goodness. Sorry to bounce in like that on the microphone. It seems to me there might be 1,000 questions. I developed a few just as I was sitting and listening, but maybe I could ask a couple of them.
Sure.
What does the FDA's role in this process stand up to at this point? What's the
that's a great question, and luckily for this, at this point, there is no role, because what we're doing is we are using already FDA-approved drugs off-label, which is one of the things that I, as a physician, am allowed to do. So up until this point, I was just treating patients. I was not doing a study. I wasn't trying to prove that this should be approved and by all insurance companies. I was just treating patients. The FDA will come into it probably in the next year when we get enough help to financially actually try and run some studies on this. Eventually, they're going to have to be done. I've got no doubt that one way or another, this is going to make an impact. And I think the FDA is going to look upon this very positively, because we're not, the only thing that's new is the ablation. And, I don't think that that's anything they're going to have a real problem with.
understand that, excuse me, cryoablation cause sexual dysfunction. Is that true?
Um, there's a lot of misinformation out there about cryoablation. Cryoablation, when we first started, was a completely whole gland treatment. And when you do cryoablation of a whole gland, just like if you did a radical prostatectomy without nerve sparing, 100% of patients are going to be impotent. Okay? They can do radical prostatectomies now with nerve sparing, but interestingly enough, it does leave patients with cancer left behind in a not insignificant group. So 25% of patients who have radical prostatectomy, the cancer is not completely removed. That's one thing you should that's a fact that you should know. And if you know somebody with cancer, prostate cancer, and they're thinking of choosing a treatment, ask them before they choose a radical prostatectomy if they know what a positive margin is. Positive margin means cancer is left behind after the removal of the gland. I can tell you that 99 out of 100 patients are never told that they have a 1 in 4 chance of not having their cancer completely removed. What happens to those patients? They go on to radiation therapy on top of their radical prostatectomy. That is not a great combination. Okay? So, getting back to your question, I got off on that, stood up on my box here. The sexual dysfunction of cryo was because of a whole gland treatment. And we hardly ever have to do a whole gland treatment anymore. We do a good biopsy, what we call a 3D mapping biopsy. We find out exactly where the cancer is, and then we focus in on the cancer. And under those circumstances, there's about a 90% potency rate, which is significantly better than a radical prostatectomy. So old data the way we used to do it, but we don't do it that way anymore.
I have two questions. One, if somebody had non-metastatic prostate cancer right now, would you use this new treatment? Could you? Would you? And the second question goes back to diagnosis. I know you do the mapping, the transperineal biopsy. Can you do targeting, either with, in an MRI or UroNav system or whatever?
Yeah, you can do same way that you can do a UroNav system. There is software available to overlay an MRI onto your ultrasound at the time of the biopsy, so that you can biopsy with guidance in the MR as the guidance. What we have found is that MR misses about 15% of significant tumors. So it just doesn't show them. And if you're talking about a Gleason 6 cancer, it's missing about 40% of those. It's okay if you say, well, it's Gleason 6, we don't have to worry about it. Well, there are aggressive forms of Gleason 6. So you should find it and then test it. And you can do genetic testing now on the cancer and find out what its aggressive potential is. But to stick your head in the sand and say, it's just a Gleason 6, don't worry about it. So while we do get MRIs, we don't feel, and they can be helpful, we don't feel that they replace a good transperineal mapping biopsy under heavy sedation or general anesthesia. That way, we really find out what a patient has and can treat it correctly the first time. And I don't remember your first question anymore. Yeah, we already are. Now that we are feeling comfortable with the low morbidity of the associated medications, because of the way we do our treatment and the doses we use and the way we deliver it, we're not seeing the same complication rates as you see with the treatment in other cancers the standard way. So once we saw that the risks of doing the treatment were not too great, then we started looking at guys who had very high-risk cancer, Gleason 9, young person with a Gleason 8. Those guys, we're now offering the potential of having this as an adjuvant treatment. Because, frankly, if it was me, this is what I'd be doing. That's my golden rule. I'm not doing anything to anybody that I wouldn't have done. And if I had a high-grade cancer now, rather than take the chance of 40% failure or 50% failure down the line, I would be treated with this and hope I didn't get some irrevocable new complication of these medications, which, so far, we're not seeing. So, but yeah, if I had high aggressive cancer, this is what I'd be doing. Because it also gives us a chance, it also gives us a chance to get a full treatment of the prostate cancer with virtually no morbidity. Because the immune system kills the prostate cancer. So the kind of ablation that you have to do to kill the cancer becomes much less aggressive in a way. So that's another advantage of it. If you get you look at this guy. He had this aggressive cancer, extracapsular, already metastatic, and he has had no local complications, didn't even twitch. That was almost 6 months ago. Yeah, recently. We've only been doing this about 11 months. We've got the first paper written. We're just finding the right time to send it in. Yes?
Doctor, what do you recommend for a patient that has metastatic prostate cancer already? They've had a radical prostatectomy and they've had radiation treatments, and PSA is rising again. What kind of treatment would you recommend for that patient?
Well, the standard treatment is going to be ADT, hormone ablation therapy. Good hormone ablation therapy is the standard treatment. That person would be put on Lupron, should have Casodex added to it, and then we use a third drug, usually Avodart. Now, we have a couple of guys who had recurrences after the first patient I showed you was a guy who had recurrence after radiation and a radical prostatectomy and had local disease growing. And it just got completely out of hand and metastasized, and we've got a couple of guys now who were doing well. We were able to find cancer locally, even though they didn't have metastatic disease grossly, and we can treat them in terms of their local recurrence and add the immunotherapy. So I think that is a very reasonable approach. Now, some patients would say, okay, well, I'll do that after I fail the hormone therapy. We feel strongly enough that I'm not, a patient who's in that situation is in dire straits. Risks of doing this are far less than the risks of doing a traditional treatment. That's where I'm sitting right now in terms of that type of patient.
That's available before 5 years from now?
Oh yeah, no, we're doing this now. Whenever a patient comes to us, And we're being referred patients. I mean, you can imagine the urologist that got that patient back, that first patient. I mean, this is kind of spreading. The word is spreading through the underground, and there are oncologists and there are patients that are being sent to us now for this. The biggest downside is right now we do not have financial support for this program, and the medications are unbelievably expensive. That's the problem. They are grossly expensive.
That was going to be my question, was what it would cost to go through a procedure.
Yeah, it's, you know, the medications, each treatment is almost close to $20,000 just from, and the insurance doesn't pay for it because it's off-label. So that has been a limiting factor. In my results, there were some patients that had a result but didn't get a complete response. Unfortunately, those are patients, a couple of those patients weren't able to get a second dose because they couldn't afford the medications. We're hoping, and we don't charge for the medications. I mean, we just buy them and pass them on to the patient. It's not like we, you know, upcharge that to, you know, make some money. It's just hallucinously expensive. But we're hoping that we can get some support in not too distant future so that that is not a limiting factor.
Any other
If you
thoughts?
know, if anybody knows a philanthropic billionaire, just pass him our way. Okay? Donald Trump. Yes.
I was going to
Well,
ask, what can we do to help?
I could tell him that what we're doing is great.
Great for America.
Great, great, great. We've got a great new treatment. So that's pretty much it. Yes. Mm-hmm. That is, no, we're not in Celebration anymore. We are down in Aventura, and we're still not taking, you know, Medicare. It just, there is no way that we can work and give the kind of care and things we want to do under that system. Just the way it is. And so, you know, we just had to go away from it. We're not happy about it, but
Realities.
one of the realities.
Yeah. Anybody else? Anything?
You know, it's a good question. We have not, I've tried to get to Dr. Myers to actually present this to him, because we know each other. And he's been kind of off the radar for a little bit. I think he's winding down his practice, and never really to get a full presentation of what we're doing. He's one of the first guys that I wanted. Therapy. He used leucine a lot and things like that. And you know, with the results we're getting, you know, I wanted to let him know about it, but we haven't had a chance to really talk to him about it yet.
Certainly offers some tremendous possible changes in the whole field, it seems to me.
That's what we're, look, when I'm not new at doing new things. I'm old at doing new things. You know, we were the first ones we did the first cryosurgery, we did the first irreversible electroporation, we did the first focal therapy ever. And at each one of those times, I really felt like it was going to be a watershed event. And in some ways it was. I mean, focal therapy is now used every way we proposed it necessarily, even though I think that the way we proposed it was the right way to do it. But it's everywhere. This is another one of those times where I think we're at a watershed event, where things won't be the same after that. And it's all based on the stuff that we learned going forward. I mean, we had to become experts in ablation before we could apply it in this way.
I know our own Dr. Alan Treeman is always stating how the last 5 years have been remarkable in this whole prostate cancer field as opposed to the previous 30 that he's been in it.
Oh, and you've got a great guy, here in Allen, who does focal therapy, and Winston Barzell, and terrific guys.
Well, thanks, guys, and thanks,
Thank you
Dr.
very much.
Onik. That was very, very enlightening and something for us to all think about. And I think
In the next year, I can guarantee you that one day you'll be looking on the TV and there'll be a story on this, and you'll go, I heard it first.
that's right. Yeah. Somebody else mentioned that, a
What?
Time magazine article about this. A few, Are you familiar with that?
Yeah. On
We'll have to get that.
Oh, absolutely. Immunotherapy is here to stay. There's no question. Yeah, yep. What's new about this is that we've made it work for prostate cancer where nobody has before. And there's no question in my mind that because we made it work for prostate cancer, that we'll be able to make it work for other things as well. Pancreatic cancer, a whole host of other things. That's another exciting part of this, that we've taken a non-immunogenic tumor and made it work, which means that the other things that these drugs have failed with, such as pancreatic cancer, now become possibilities. Imagine if we got these results in pancreatic cancer. So, thank you
Thank
for
you,
your
guys.
attention, and thank you for coming back. I appreciate
Thank
it.
you. Thanks so much, Dr.